This morning I'm going to talk about really about process and how to go about considering whether or not you want to do outpatient total joints in your ambulatory surgery center. And if you do decide to, what's the process? A lot about how and what. So today's objectives, we're going to review current trends in outpatient total joint replacement, why this shift is occurring. We're going to look at the challenges and the opportunities and the advantages of providing arthroplastic surgery in the outpatient setting. We're going to help you understand the process, patient selection criteria, some examples there, and the implementation steps required to successfully perform outpatient hip and knee replacements. We're going to go over some of the pre-op, perioperative, and post-op protocols. I'm not going to go into a lot of great detail. I think you heard some of the other speakers speak to those in today's presentation, because I'm going to really focus on process. And then we're going to review the clinical, the financial models that are coming forward, the bundled payments, particularly around total joints. So where do we start? If you've just worked through all of those 8 key considerations, and the answer is yes, we're going to move forward, you're certainly going to want to engage the surgeons and the staff in the planning process. You've got to get those key leaders on board, helping to create that vision. We had one facility where the PACU nurses just did not believe in this whole project, and it was really going to impact the patient care, because if the patients sense that, they know that if the nurses don't believe in this, it's probably not a good place to have their surgery performed. So making sure everyone's engaged. You need key surgeons that are leaders and administration to drive the process. And then you need to really do a deep dive into the current state. You need to look at your physical space. You need to look at your instrumentation and equipment needs. I mentioned the staff competencies earlier, the surgeon commitment in the current protocols, decreasing those variances so that you can provide this service as cost-effective as possible. You need to have a very clear vision and very clear goals and timelines. Determine your startup cost. Make sure your pro forma is very detailed so everyone knows exactly what the expectations are, and then have a timeline. If you don't have a timeline to when you're going to launch your new service, it can go on for years, unfortunately. So making sure that you're holding people accountable, that you're engaging everyone in the process, the surgeons are driving those standardization processes, and that you've got a clear reimbursement strategy. Are you going to carve out your implants? Are you going to carve out rehabilitation? How are you going to design that bundled payment? Making sure that those third-party ancillary services are on board, that they're understanding what your expectations are for any post-op needs for your patients, and then making sure you have an emergency plan. The worst thing you can have happen is that patient goes home, they have uncontrolled pain, they call in, and perhaps they get a hold of another physician that's on call that may or may not be aware of what's really going on in the ASC, and the patient ends up admitted. So you want to make sure everyone's on board, that there's a clear communication plan between all the providers, and that you have everyone's informed about that. You want to stage your launch. You don't necessarily want to try to do 10 joints your first day. Some physicians have that goal, but you really want to stage that launch. You want to look at what is the length of stay for the surgeons that are going to be bringing these services to your ASC. And you know, what is their length of stay on the inpatient right now? If they're currently still at 2 to 3 days, you really want to work with them to get them down to about a day, day and a half before you start pulling them across. You can start with partials, obviously, on the commercial and Medicare side. Medicare does not approve totals at this point, but on the commercial side, then you can build on that volume gradually. So build a realistic pro forma. I know a lot of the docs get really gung-ho about this, but make it realistic so that you can safely and comfortably be able to provide this service in your ASC. Now, I bring up the Joint Commission and the disease-specific certifications for this reason. How many of you are familiar with these programs on the inpatient side? Very good, very good. Well, from our discussions with both the Joint Commission and Blue Cross and Blue Shield, they're transitioning these to the outpatient. So as you develop your program, you want to be aware of their criteria. We'll talk about the Blue distinction first. It's a very comprehensive prescriptive criteria set. There's probably It's probably 30 pages long. You can get it online. What they do not share is their weighted scoring mechanism anymore, but you can see their criteria and what they're looking for results. The Blue Distinction Plus, Center Plus designation are those facilities that meet their cost of care performance expectations. So you want to look at these 8 categories, and there's a lot of criteria underneath each of these that you want to familiarize yourself with. But physician expertise and leadership, they look for board-certified physicians. They look for how are the physicians engaged in the process. For volume, they look at physicians that are doing at least 75 procedures per year. They look at outcomes and safety. They look at infection rates, readmission rates, admission to hospitals, et cetera. Cost of care, pretty straightforward. Evidence-based care, they like to see how you are using evidence to drive your standardized protocols and processes. They look at, do you have a dedicated facility? On the inpatient side, they like to have dedicated units. Obviously, that doesn't pertain to the ASC, but they will look at your staff competency. They will pull files. They will look at how are you training your staff specifically to total joint replacement. And patient preparation and education. What are you doing to prepare the family for the experience? They are in process of adjusting this criteria to be able to designate those networks on the outpatient side in preparation for more and more total joints going to the ASC setting. The Joint Commission is the disease-specific certification for total hip and total knee. It's a separate certification. It is not prescriptive. It is very process-oriented, outcomes-oriented, and basically they ask the facility to decide what their process improvement initiatives are. And this is new for ASCs. Some ASCs have very robust quality improvement programs. Some are very elementary. So you're going to want to take a look at that as you design your service so that you're prepared for these as they come forward in the future. Comprehensive integration, as you look at that patient experience, and really patients are driving a lot of this. As you look at health and wellness, we have a lot of facilities that are starting to adopt some wellness techniques and really customizing the patient experience so it's more, it's not so hospital-like. The ASC is not hospital-like in their environment anyway, so by adding just a few very, very low-cost amenities such as aromatherapy or music therapy, which doesn't cost a lot at all, it really can make that patient experience much more robust. Now here's an example of patient selection process. We talked about that a little bit ago. Just an example for green light, you certainly want to have educated, prepared, motivated patients. Certainly they have to meet the criteria for the procedure to be covered. You want to make sure they have appropriate insurance coverage, that they're functionally independent. Do they have help at home? Do they have someone that can help them recover? And that they've completed a comprehensive pre-screen H&P, that they've attended a pre-op class or gone online to review the materials. And typically we see the ASA type 1 or 2, mostly 1. Now on the red light, again, this is an example. You can get as detailed as you want, but the important thing here is that you're very specific so that everyone on board understands what patients are going to be done in the ASC and which ones would not qualify. So here's some examples of, cardiac conditions. Certainly previous MI would be of concern, any pulmonary disorders. Some set the BMI at 35, most go 40. You can see the other diseases or concerns there that you'll want to consider. So again, you can get very, very detailed. I've seen lists as long as about 70 different indicators here. Some start smaller, but my advice is to start broader so that you really are starting with very healthy patients so that you can get your legs under you as you get started. The need for pre-op education and preparation, certainly I talked about the shift in the perception of the need for inpatient care from patients, making sure that they're confident that this is a good option for them. You may want to include a facility tour, introduce them to some of your staff, making sure that they've been well prepared. Some of the centers are doing a pre-op patient PT evaluation rather. to teach them how to do gait walking, ambulation, speeds it up on the back end of the procedure side. It doesn't have to happen, but a lot of them are doing that, and certainly improving the patient and family preparation. The more the family's prepared, because the patient's not going to remember a lot that day, obviously, so making sure that their family members, significant others, well prepared. And then the day of surgery, making sure it's very easy and convenient, that the flow's very comfortable, that it's a wellness environment, great communication with the family, and a smooth transition back home. Now, let's talk a little bit about the transition home and the follow-up care. Very, very important. A couple of the surgeons have told me that when they started their program, they actually called the center a couple times during the night. They kept them overnight in the ASC to start with, and a couple of them called during 2 or 3 hours, every 2 or 3 hours during the night to make sure things were going well. I think the key message is that the physicians are accountable for that care. And so making sure that you've got those processes, whether the physician calls the next day or it's a staff member that calls the next day, just making sure that the follow-up appointments are scheduled, that the patient's well prepared. And there's a lot of new technologies coming out in this area as far as Skyping with the patient and different innovative type of ideas. It's pretty exciting to watch. I talked about the emergency plan. The main thing that we hear in our experience over the last 4 years has been pain management, nausea primarily, and making sure that there's a plan for that and that patients are well prepared. So again, the last thing you want is them to access an emergency room or have any complications. So setting patient expectations and family education is very, very key to avoiding that.